Hello and welcome to our new topic on antibacterial drugs which act by targeting bacterial DNA replication. In today's lecture, we will discuss an extremely important class of antibacterial drugs known as quinolones and fluoroquinolones. These drugs have become some of the most widely prescribed antibiotics in modern medicine because of their broad spectrum of activity, excellent oral bioavailability, and ability to achieve therapeutic concentrations in many tissues of the body. So, let's start. The learning objectives of this lecture series are listed here. Please take a look. By the end of the lecture, you should be able to understand not only what these drugs are, but also why different quinolones behave differently in clinical practice. Before focusing on quinolones and fluoroquinolones specifically, let us place them in the broader context of antibacterial pharmacology. Antibacterial drugs work by targeting structures or processes that are essential for bacterial survival. For example, the bacterial cell wall is targeted by drugs such as penicillins, cephalosporins, carbapenems, monobactams, and vancomycin. Protein synthesis is targeted by tetracyclines, aminoglycosides, macrolides, chloramphenicol, and several other groups. These drugs interfere with bacterial ribosomes and prevent production of essential proteins. Antifolate drugs such as sulfonamides and trimethoprim inhibit different steps within this pathway and thereby prevent the production of compounds that are essential for DNA synthesis and cell division. The bacterial cell membrane is targeted by polymyxins and a few other agents. Finally, the nucleic acid synthesis can be inhibited by drugs such as fluoroquinolones and rifampicin, which interfere with DNA replication or transcription. Notice the highlighted region in the diagram showing DNA gyrase and topoisomerase enzymes. These enzymes are essential for DNA replication and chromosome maintenance. If these enzymes are inhibited, bacterial DNA can no longer function properly, replication stops, and the bacteria eventually die. Therefore, quinolones are bactericidal drugs because they kill bacteria rather than merely inhibiting their growth. Let us briefly look at the chemical structure of this group of drugs. On the left side, you can see the general quinolone nucleus. This core structure serves as the foundation for all drugs in this class. In the center, we have nalidixic acid, which is considered the prototype or first-generation quinolone. It was one of the earliest members of this class and was mainly useful for urinary tract infections. On the right side, you can see examples of fluoroquinolones such as ciprofloxacin and ofloxacin. Notice the presence of a fluorine atom in these molecules. The addition of fluorine dramatically improved antibacterial activity, tissue penetration, pharmacokinetic properties, and overall clinical usefulness. To understand how quinolones work, we need to appreciate a mechanical problem that occurs during DNA replication. As the DNA double helix begins to unwind during replication, tension builds up ahead of the replication machinery. You can think of this in the same way that a telephone cord becomes twisted when repeatedly rotated. The image on this slide illustrates this concept. A simple coil can become further twisted, producing structures known as supercoils. Similarly, when bacterial DNA is unwound for replication or transcription, excessive supercoiling develops ahead of the replication fork. If these supercoils are not removed, DNA replication eventually comes to a halt because the DNA becomes increasingly tangled and difficult to separate. Therefore, bacteria require specialized enzymes called topoisomerases that can relieve this torsional stress and maintain DNA in a functional state. Now that we understand what supercoils are, let us see how bacteria deal with this problem. As DNA replication proceeds, positive supercoils accumulate ahead of the replication machinery. These supercoils create mechanical stress and make further unwinding increasingly difficult. The solution is provided by enzymes known as topoisomerases. These enzymes temporarily cut the DNA strands, allow the twisted DNA to relax, and then reconnect or relegate the strands. This process removes excessive supercoiling and restores the DNA to a functional state. Think of it as entangling a twisted rope. If you simply pull on the rope, the tension increases. However, if you briefly release one end, allow the rope to untwist, and then reconnect it, the tension disappears. DNA gyrase is a special bacterial topoisomerase. In addition to removing harmful supercoils, it can also introduce negative supercoils, which facilitate DNA unwinding during replication and transcription. Without these enzymes, bacterial DNA replication would rapidly stop. Therefore, DNA gyrase and topoisomerase IV are essential enzymes for bacterial survival. Fluoroquinolones primarily inhibit two bacterial enzymes, DNA gyrase and DNA topoisomerase IV. However, the preferred target differs between gram-negative and gram-positive bacteria. In gram-negative bacteria, DNA gyrase is usually the primary target. In gram-positive bacteria, DNA topoisomerase IV is generally the primary target. This distinction helps explain why different fluoroquinolones may demonstrate slightly different antibacterial spectra. The table at the bottom summarizes another important concept. DNA gyrase is predominantly associated with gram-negative organisms. Topoisomerase IV is particularly important in gram-positive organisms. In contrast, eukaryotic cells possess topoisomerase II. Although it belongs to the same general family of enzymes, its structure differs sufficiently from bacterial enzymes to allow selective toxicity. This difference explains why fluoroquinolones can inhibit bacterial DNA replication much more effectively than human DNA replication. Fluoroquinolones often work well in combination with aminoglycosides and beta-lactam antibiotics. Such combinations may be used in severe infections because the drugs attack bacteria through different mechanisms simultaneously. This slide builds upon the concept we just discussed. Students often assume that gram-negative bacteria contain only DNA gyrase and gram-positive bacteria contain only topoisomerase IV. In reality, both enzymes usually coexist in bacterial cells. The difference lies in which enzyme is more critical and which enzyme is more sensitive to inhibition. Let us look at the illustration. At the front of the replication fork, DNA gyrase relieves torsional strain, introduces negative supercoils, and facilitates DNA unwinding. Behind the replication fork, topoisomerase IV performs a different but equally important role. It separates newly replicated daughter chromosomes, a process known as decatenation, and ensures proper chromosome segregation during cell division. Therefore, both enzymes contribute to successful bacterial replication. An important advancement occurred with newer fluoroquinolones. Rather than predominantly targeting one enzyme, some agents can inhibit both DNA gyrase and topoisomerase IV effectively. This dual inhibition is known as the parallel blockade phenomenon. Because the bacterium is attacked at two essential points simultaneously, antibacterial activity may increase and the likelihood of resistance development may decrease. Also notice the note regarding eukaryotic topoisomerase II. Human topoisomerase II has a different structure and mechanism, which contributes to the selective action of these drugs against bacteria. The concept of parallel blockade becomes particularly important when we discuss newer generation fluoroquinolones. This is one of the highest yield slides in the lecture, so let us study it carefully. The evolution of quinolones can be viewed as a gradual expansion of antibacterial spectrum and clinical utility. Generation classification varies between sources. The key message is the progressive expansion of gram-positive, atypical and anaerobic coverage. First-generation quinolones, shown in red, include nalidixic acid and sonoxacin. These older agents primarily target DNA gyrase and are largely confined to urinary tract infections because they achieve useful concentrations mainly in urine. Second-generation fluoroquinolones include agents such as norfloxacin, lomafloxacin, ofloxacin, and ciprofloxacin. Notice the major improvement here. These drugs retain strong gram-negative activity and gain excellent activity against Pseudomonas aeruginosa. Ciprofloxacin became the classic anti-pseudomonal fluoroquinolone and remains one of the most important drugs in this class. Third-generation agents, represented by levofloxacin, demonstrate improved activity against gram-positive organisms, particularly streptococci. This is why levofloxacin is often referred to as a respiratory fluoroquinolone. Fourth-generation agents such as moxifloxacin and delafloxacin provide more balanced inhibition of both DNA gyrase and topoisomerase 4. Although many drugs cover MRSA, delafloxacin is unique among commonly used fluoroquinolones because it retains useful MRSA activity. As you move across the table from left to right, notice how the spectrum gradually expands. Initially, coverage is limited mainly to Enterobacteriaceae. Then activity against Pseudomonas appears. Next comes coverage of atypical pathogens. Then, improved streptococcal coverage. Finally, activity against anaerobes and, in the case of delafloxacin, activity against MRSA. One particularly important examination point appears in the note at the top right. Although moxifloxacin has excellent respiratory and anaerobic activity, it is not useful for urinary tract infections because it is excreted through the biliary route and does not achieve adequate urinary concentrations. Therefore, spectrum alone does not determine clinical usefulness. Drug distribution is equally important. Having seen how the spectrum evolved, we can now appreciate why these changes occurred. This slide illustrates the structure-activity relationship, often abbreviated as SAR. The central quinolone nucleus is essential for antibacterial activity. The highlighted carbonyl and carboxyl groups are particularly important because they participate in binding to the DNA gyrase DNA complex. Around this nucleus are several positions where chemical modifications can be introduced. Notice the color coding in the diagram. Certain substitutions enhance gram-negative activity. Other substitutions improve gram-positive activity. Some modifications broaden activity against both gram-positive and gram-negative organisms. Still others enhance anaerobic coverage. This explains why modern fluoroquinolones differ so significantly from the original nalidixic acid molecule. Medicinal chemists were able to strategically modify specific positions on the quinolone nucleus to improve potency, broaden antibacterial spectrum, enhance pharmacokinetics, and reduce limitations of earlier agents. You do not need to memorize every position shown in this diagram. Instead, remember the broader principle. Small structural changes in the quinolone molecule can produce major changes in antibacterial activity and clinical usefulness. That principle explains the progressive evolution from first-generation quinolones to the modern fluoroquinolones used today. Modifying the quinolone molecule may yield a diverse set of activities beyond bacterial biology, as shown in this slide. Unfortunately, like all antibacterial agents, fluoroquinolones are vulnerable to bacterial resistance. The most important mechanism involves mutations in the genes encoding DNA gyrase or topoisomerase 4. Remember that these enzymes are the primary targets of fluoroquinolones. If mutations alter the drug binding site, the antibiotic can no longer bind effectively, and resistance develops. Another important mechanism involves decreased intracellular drug accumulation. This may occur because bacterial porin channels become less permeable, reducing drug entry into the cell. Alternatively, bacteria may overexpress efflux pumps that actively remove fluoroquinolones from the cytoplasm before they can exert their effect. Some bacteria possess plasmid-mediated resistance mechanisms that further reduce susceptibility. Notice that resistance often develops stepwise. A single mutation may produce low-level resistance, while multiple mutations can result in high-level resistance. This explains why inappropriate use of fluoroquinolones can accelerate resistance development. It also explains why newer fluoroquinolones that effectively inhibit both DNA gyrase and topoisomerase IV may be somewhat less susceptible to resistance arising from a single mutation. One of the major reasons for the popularity of fluoroquinolones is their excellent pharmacokinetic profile. Most agents in this class are well absorbed after oral administration. In fact, some achieve oral bioavailability approaching that of intravenous administration. This means that many patients can be switched from intravenous to oral therapy without a significant loss of efficacy. After absorption, fluoroquinolones distribute widely throughout the body. They penetrate the lungs, kidneys, prostate, skin, soft tissues, macrophages, and neutrophils. This excellent tissue penetration contributes greatly to their broad clinical utility. Notice the mention of intracellular accumulation. Because fluoroquinolones enter phagocytic cells efficiently, They are particularly useful against intracellular pathogens such as Legionella, chlamydia, and mycoplasma. Elimination varies among individual drugs. Ciprofloxacin and levofloxacin are primarily eliminated through the kidneys and achieve high urinary concentrations. Moxifloxacin, however, undergoes significant hepatic handling and biliary excretion. Consequently, urinary concentrations are relatively low, explaining why it is not preferred for urinary tract infections. This slide reminds us that pharmacokinetics often determines where a drug can be used successfully, not merely which organisms it can kill. Although fluoroquinolones are highly effective antibacterial agents, they are associated with several important adverse effects. Gastrointestinal symptoms such as nausea, vomiting, and abdominal discomfort are relatively common but usually mild. Central nervous system effects may include headache, dizziness, insomnia, agitation, and, in susceptible individuals, seizures. One of the most important musculoskeletal toxicities is tendinitis and tendon rupture, particularly involving the Achilles tendon. The risk is increased in elderly patients, transplant recipients, and those receiving corticosteroids. Another well-known concern is cartilage toxicity. For this reason, fluoroquinolones have traditionally been used cautiously in growing children and during pregnancy. Cardiac effects are also important. Some fluoroquinolones can prolong the QT interval and increase the risk of arrhythmias such as torsades de pointes. Photosensitivity may occur with certain agents, causing exaggerated skin reactions after sun exposure. More recently, regulatory agencies have highlighted rare but potentially serious adverse effects involving the peripheral nervous system and connective tissues. Although these toxicities are uncommon, they remind us that fluoroquinolones should be used judiciously and only when clinically indicated. The key point is that these drugs are highly effective, but they are not completely benign. This is one of the most fascinating slides in the lecture because it illustrates how drug development continues even after a drug reaches the market. Several fluoroquinolones were introduced with great expectations but were later withdrawn because of unacceptable toxicity. As you examine the table, notice the variety of adverse effects responsible for withdrawal. Some agents caused severe hepatotoxicity. Others were associated with serious cardiac arrhythmias due to QT prolongation. Certain drugs produced severe phototoxicity, while others caused unacceptable neurological or metabolic adverse effects. The important lesson here is that approval of a drug does not mark the end of safety evaluation. Rare adverse effects may only become apparent after millions of patients have received the medication. This slide also helps explain why regulatory agencies closely monitor post-marketing safety data. For students, the individual withdrawn drugs are less important than the principle they illustrate. Namely, every antibacterial drug represents a balance between efficacy and safety. The history of fluoroquinolones demonstrates how improvements in antibacterial activity must always be accompanied by careful monitoring for toxicity. As future healthcare professionals, it is important to appreciate both the therapeutic power and the potential risks of these agents. Before moving to the summary slides, it is important to discuss a few clinically relevant drug interactions of quinolones. The first important interaction involves divalent and multivalent cations. Oral quinolones combined with calcium, magnesium, aluminum, iron, and zinc. These ions are commonly present in antacids, iron tablets, calcium supplements, multivitamins, and some dairy products. When taken together, they form chelates in the gastrointestinal tract, and this markedly reduces quinolone absorption. Therefore, oral quinolones and many other antibacterial drugs should not be taken at the same time as antacids or mineral supplements for this reason. The second important interaction is with NSAIDs. NSAIDs may increase quinolone-related central nervous system stimulation, possibly by enhancing interference with GABA-mediated inhibition. This may contribute to adverse effects such as nervousness, insomnia, dizziness, and rarely seizures. Another classic interaction is with theophylline. Ciprofloxacin, pefloxacin, and grepafloxacin can increase theophylline levels, which may lead to toxicity such as tachycardia, tremor, nausea, and arrhythmias. Finally, quinolones may show synergism with aminoglycosides and beta-lactam antibiotics, especially in severe gram-negative infections. This is not simply an interaction to avoid, Rather, it may be therapeutically useful when drugs attack bacteria through different mechanisms. So the key practical message is, separate quinolones from minerals, be cautious with NSAIDs and theophylline, and remember that selected combinations may be useful in serious infections. Rather than memorizing individual drugs, it is often easier to understand how the spectrum changed over time. The earliest quinolones primarily targeted gram-negative urinary pathogens. Their usefulness was largely confined to urinary tract infections. The next major advancement was improved activity against gram-positive respiratory pathogens, particularly Streptococcus pneumoniae. This led to the development of respiratory fluoroquinolones such as levofloxacin. Further modifications produced agents such as moxifloxacin, which added improved anaerobic coverage and excellent activity against atypical respiratory pathogens. Finally, newer agents such as delafloxacin expanded activity even further by providing useful coverage against MRSA. The 4 drugs given as examples are the most commonly used ones. A pink, purple or mixed color in their names indicate gram-negative or positive spectrum. This table on the current slide and the next provides salient features of various clinically used fluoroquinolones. The generations, availability and most important drugs are color-coded. The current view only includes second and third generation drugs. This slide shows the newer fluoroquinolones in the same way. Note that gadafloxacin is an example of a drug which, despite being withdrawn from market in terms of systemic use, continues to be used topically. Also note that a 5th-generation fluoroquinolone class is being developed with focus on parallel block and efficacy against MRSA. Now let us bring everything together and examine the major clinical applications of these drugs. Fluoroquinolones are used in a wide variety of infections because of their broad spectrum and excellent tissue penetration. The important point here is that every fluoroquinolone has strengths and limitations. There is no single, best, fluoroquinolone for every infection. Instead, clinicians select a specific drug based on the likely pathogens, the site of infection, local resistance patterns, and pharmacokinetic properties. Urinary tract infections remain an important indication, particularly for agents such as ciprofloxacin and levofloxacin that achieve high urinary concentrations. Respiratory tract infections are another major indication, especially when respiratory fluoroquinolones are used. These drugs are also useful in certain gastrointestinal infections, traveler's diarrhea, typhoid fever, and selected intra-abdominal infections. Ciprofloxacin remains particularly important for infections caused by Pseudomonas aeruginosa. Delafloxacin may be useful in selected skin and soft tissue infections where MRSA coverage is desired. As you review this slide, remember that successful antimicrobial therapy depends on 3 factors. 1. The pathogen must be susceptible. 2. The drug must reach the site of infection, and 3. The patient must tolerate the medication safely. The clinical usefulness of fluoroquinolones results from their ability to satisfy all 3 requirements in many common infections. We have now completed our discussion of antibacterial quinolone and fluoroquinolone drugs. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!